you for joining our Nova Scotia COVID-19 EMS Journal Club. We hope that we'll have more of these over the coming few weeks or months in relation to COVID-19 and current research and practice. My hope is that these journal clubs will be a venue for discussing research evidence, along with also providing paramedics with the opportunity to discuss practice. And we'll try opening it up for conversation later on, potentially, but we'll see how it goes today, and we'll welcome feedback. Our goal is to present and discuss the evidence taking into consideration paramedic practice, particularly in Nova Scotia. And we have a few subject matter experts on the line around clinical care and occupational health and safety, and they may jump in as well if Jen and I are throwing out things that we typically don't do in Nova Scotia, so they might follow up with some practice that is happening here. I would like to thank Jen as well. She's an advanced care paramedic and paramedic KT coordinator with the Dalhousie Division of EMS for helping to lead this journal club. And in Nova Scotia, we can use journal club participation as CEUs for the College of Paramedics of Nova Scotia. So I wanted to highlight that as well. I also wanted to first acknowledge that the first responders, including paramedics and dispatchers who attended to the incident on April 18th and 19th in Nova Scotia, and in particular pay our respects to the RCMP officer who lost her life in the line of duty, Constable Heidi Stevenson. As most of you may be aware, a moment of silence will be held today at 2 p.m. to honor Constable Stevenson. And there's an online vigil tonight via social media, and I believe potentially being broadcast through the CBC as well. I also wanted to highlight there are a number of options for EMC employee support through our internal website for Pulse and Pair and Family. I didn't list all the different supports that we have, but there are a number. And then also through the NSHA, Nova Scotia Health Authority. And from a research perspective, I also wanted to highlight the work of the Canadian Institute for Public Safety Research and Treatment. They have a lot of research, or a lot of screening tools and interventions to support resiliency among first responders on their website as well. So just wanted to highlight their work. So Jen and I have no conflicts to disclose, no stakes in any or stock in any drug companies that I know of. But we are affiliated with the Pre-Hospital Evidence-Based Practice Program, or PEP, Paramedic Evidence-Based Practice course through the Dalhousie Division of EMS. Our objectives for today are to really talk about two articles in relation to cardiac arrest care in the context of COVID-19, and also to talk about personal protective equipment. We may have integrate some discussion around rapid review methodology, and then as time permits, open it up for discussion, but please feel free to use the chat box and post comments or questions there as well. And as a disclaimer, as I already mentioned, Jen and I may hand it over to subject matter experts from Nova Scotia in terms of clinical practice here and occupational health and safety if need be, and also consult your resources for whichever service you are affiliated with. In Nova Scotia, we have an EHS app, which is great for clinical and policy references. So in terms of COVID-19, there's been a ton of studies published really since January 2020. We're over 6,000 studies now, and a lot of them are open access. And as we've seen over the past couple of weeks, it is important for clinicians to be able to critically appraise these articles. We've seen a lot of research being thrown around the general media and really not interpreted correctly. So it's good to be able to critically appraise research that is coming in. I also wanted to highlight that paramedics have been on the front lines of caring for patients with COVID-19 and also on the cover of Tide. So we wanted to offer this journal club to support frontline clinicians, in particular paramedics, and I think we have a few EMS physicians on the line as well, and hope that this might be venue for paramedics and others to come together to discuss research and share insights into practice. So when healthcare professionals are asked what they want of their organizations during this pandemic in particular, these are the things that they typically say. I'm hoping that this journal club, and if we have future ones, that journal clubs in general can fill some of these gaps and provide in particular an opportunity for paramedics to be heard, and also an opportunity for paramedics to feel prepared by learning about the research that is out there in certain conditions and practices. I also want to give a quick plug again to the pre-hospital evidence-based practice program. We've added a section on coronavirus, and Jen has been searching the literature over the past month to populate that site. If anyone's interested in helping us reviewing articles for that site, we hope it's a way to curate research that is applicable for paramedics. Please feel free to email Jen at j.greene@dow.ca or the pap@dow.ca. I want to start by highlighting a narrative review published by Jason Buick and colleagues. It's open access in the Canadian Journal of Emergency Medicine. I think this is a great jumping off point to research that might impact paramedics as they care for patients with COVID-19. And today we're going to talk about cardiac arrest and PPE. Just so we're on the same page, this is the coronavirus. They've been studied and known about since the 1960s. A lot of them cause things like the common cold. But we're going to talk about coronavirus today. I know some of you might have thought that we'd be talking about frailty, but that's not the topic for today, although we might get it in there at some point. That's the coronavirus. It's known as SARS-CoV-2, that's the virus, and then the disease that it causes is coronavirus disease 19. And these are how the symptoms that are typically manifested through the illness. Fever and cough are most prevalent, but as you can see, there's a lot of different symptoms that might be observed. These are from hospitalized patients. At this point, I'm going to hand it over to Jen, and we'll talk about the first two articles on cardiac arrest. Jean, are you able to hand over control to her? You still on the line, Jen?
Oh, I'm still here.
You want me to just operate the slides?
Is Jean able to pass me control?
So I'm on the note here. Just bear with me. Jen, Judah, I'm not sure if you may have to do that because you're the one sharing your screen. I think it might have to be you. If you go up to the top there, it may give you an option. Otherwise, I just suggest that you just let him go next slide there, Jen.
Judah, can you take a look? We figured this out, I think, yesterday somehow.
Yeah, it's a different view today.
I know when I'm showing the slides, I can assign it to somebody, but it's Judah. If you go to the top there and scroll over your little menu that should be just above the presentation.
Yeah. Assign, okay. Right now it's just saying I can make Jean or Janelle the presenter. You okay if I just flip through it, Jen?
Sure.
All right.
Okay, thank you everybody for being here. Welcome to the COVID-19 EMS Journal Club. We'll do an investigation into the literature on what this means for EMS when running a cardiac arrest for our patients and for protecting ourselves. So this is a really interesting time for science because we don't have the luxury of waiting for large randomized controlled trials or time-tested longitudinal observations. We must do the best we can with what we know until we know better. And clinicians are living this pandemic in real time. To support ourselves, we must prioritize not only producing the most rigorous literature possible that time will permit, but also disseminating that information to frontline clinicians such that they are protected and as effective as our current knowledge allows. So today we'll be addressing 3 studies. I know that cardiac arrest is an area where there's a lot of questions, so we felt that this would be a good place to start. So first on deck, we have a study entitled In-Hospital Cardiac Arrest Outcomes Among Patients with COVID-19 Pneumonia in Wuhan, China. This is the first study to report on survival outcomes after cardiac arrest in patients with COVID-19. This was a single-center retrospective observational study reporting on in-hospital cardiac arrests in a hospital in Wuhan, China. The primary outcome was ROSC, and secondary outcomes were survival at 30 days and neurologic status at 30 days as per the Cerebral Performance Score. The arrests were responded to by a specialized resuscitation team who performed standard ACLS, and they used mechanical CPR devices within the ICU themselves. Interestingly, they did decide to switch compressors at 1 minute because they felt that there was difficulty doing compressions whilst wearing PPE. I can personally attest that it is difficult to run heavy calls with full PPE on, so I can appreciate that. Okay, so they identified 151 patients who had cardiac arrest, and after excluding for DNRs and incomplete data, they ended up with 136 patients. 81% were over the age of 60, and 34% were women, and the most frequent comorbidities were hypertension, diabetes, and heart disease. I'd like to point out some key demographics. The mean age here is 69, and this is consistent with other published literature. The majority of the cases where arrest occurred were in the 60 and above ranges, and I do think that we expect that. Asystolic arrest made up for the vast majority of cases, and this is higher than other estimates. Because these folks were in hospital cardiac arrest, the majority had CPR within 1 minute. And I think that that's notable. So for the next slide there. What is very different in these cases is the etiology, with the vast majority being respiratory. Other non-COVID cardiac arrests have respiratory etiologies estimated at 15% to 40% of the time. The most frequent symptoms were shortness of breath, myalgia, and cough. Only 38% had fevers, and I just wanted to highlight that because not every COVID patient presents with each one of the expected symptoms. All right, moving on to some of the key findings. Of note, the survival in the over 60 group was 1.9%. Those in the ICU were much more likely to survive. In fact, 14 times more likely to survive. And although only very few patients had a shockable rhythm, presence of VFBT was predictive of survival. They attribute the ICU difference to resources, including mechanical compression devices and advanced life support training. However, historically, neither ACLS or compression devices have been strong predictors of survival. Okay, they conclude that overall the survival outcomes were poor, with ROSC at 13.2% and survival at 2.9%. For reference, in general, in-hospital cardiac arrest has an estimated 25% survival. We can imagine that out-of-hospital cardiac arrest survival in this particular cohort would be dismal, as most patients in the study had a TEAM on their chest in under a minute. I want to point out some limitations of this study. So like we mentioned before, this is the first observational study reporting on these outcomes in COVID patients. Some limitations include not reporting on the secondary outcome of neurologic status like they had stated they were going to. And this is a red flag for me. I'd like to know why they didn't report on that, and it would be interesting to know that data. They note that there is key missing data, but they don't report how much. This is one site, and thus generalizability is limited. Few cases and few survivors make for limited confidence in these results. And there's little information on CPR quality. So what does this mean for us? This is a level 3 evidence because it's a small observational report. So if we're going by the pre-hospital evidence-based practice criteria for levels of evidence, this is a level 3, so lower level of evidence. It has limitations, but we are in a situation where we have to glean knowledge from where we can so that we can practice safely and effectively. The 30-day survival was very low, despite having many of these arrests being witnessed by healthcare providers who began CPR in under a minute. And this may mean that out-of-hospital cardiac arrest due to COVID-19 would have nearly no probability of survival, but we would need studies to determine that outcome. So, if you were like me, you were asking yourself, what do we do when we work a cardiac arrest, and what is the risk for providers? So this brings us to our second study, and this study is by the International Liaison Committee on Resuscitation, and they investigated exactly that question. And I want to highlight the importance of this type of literature, the rapid review. This design is an effective method for quickly collecting and synthesizing the answer to a question. They follow some key systematic methods to ensure as much rigor as possible, but cut some steps such that we can streamline to effectively get an answer in a timely fashion. It is an important design to use when action is immediately required, and the Dalhousie Division of EMS specializes in this design for our local practice updates. This particular review by ILCOR investigated 3 questions. First, in any setting, does the delivery of chest compressions, defibrillation, or CPR generate aerosols? Their second question, in any setting, for individuals wearing PPE, does the delivery of chest compressions, defibrillation, or CPR result in infection transmission? And finally, in individuals performing CPR in any setting, does wearing PPE versus modified PPE versus no PPE result in infection transmission, PPE efficacy, and effective CPR? So, as I mentioned briefly before, the methods for a rapid review, and this is how exactly they did it. For methods, they searched the published literature, including Medline, Embase, Cochrane Central Register of Controlled Trials, and global research on coronavirus COVID-19 gathered by the World Health Organization. One author screened for inclusion of studies with 20% checks by another author, and one author extracted data with 20% checks from another author, and that is a typical rapid review methodology. They included the following designs for studies: randomized controlled trials, non-randomized trials, cohort studies, case reports, and case series, and for the last question, they did include cadaver and simulation. So in consensus, so the answer to question 1, in any setting, does the delivery of chest compressions, defibrillation, or CPR generate aerosols? 2 case reports on suctioning and intubation reported aerosol generation. No study investigated aerosols for defibrillation. Overall, the certainty of these results was rated as very low due to serious risk of bias and serious indirectness. The consensus for question 2, which was in any setting for individuals wearing PPE, does the delivery of chest compressions, defibrillation, or CPR result in infection transmission? For the outcome of transmission itself, they included 2 retrospective cohort studies comprising of 656 healthcare workers, 1 case control study comprising of 477 healthcare workers, and 5 case reports. Of the 3 observational studies, 2 did not report a statistically significant association between CPR-related activities and infection. A case control study reported an association between chest compression delivery and SARS infection in healthcare workers. The adjusted odds ratio was 4.52 with a confidence interval of 1.08 to 18.81. 2 case reports described transmission of airborne bacterial infection in cases where CPR was delivered, including ventilation, and PPE was not worn. In 3 cases, transmission of an airborne viral infection was described, all of which had healthcare workers wearing PPE. No study investigated defibrillation-related transmission. And again, overall, the certainty of evidence was rated as very low due to serious risk of bias and serious indirectness. And the reported consensus for question 3, in individuals performing CPR in any setting, does wearing PPE versus modified PPE versus no PPE result in infection transmission, PPE efficacy, and effective CPR? For the critical outcome of PPE effectiveness, they found evidence from 1 mannequin randomized controlled trial. The study reported differences in the adequacy of protection provided by different mask types during delivery of chest compressions. Cup type had 44.9% protection versus fold type had 93.2% protection versus valve type with 59.5% protection. Evidence was rated as low, downgraded for serious risk of bias and serious indirectness. And for the outcome of CPR quality, paramedic time to complete 4 tasks, including tracheal intubation and interosseous access, was longer when paramedics wore personal protective equipment. In the no PPE group, it took 261 seconds versus full face mask was 275 seconds versus hood was 286 seconds. Personally, I do not view those as clinically significant differences, but we can discuss that. Another study showed reduced time to first compression. No gown was 39 seconds versus standard gown was 71 seconds versus modified gown was 59 seconds. Again, maybe not clinically significant. In these studies, compression quality was not impacted. Evidence certainty was again rated very low, downgraded for serious risk of bias and serious indirectness. So in conclusions, this ILCOR report recommends that all recommendations are considered weak as they have low quality of evidence. They suggest that chest compressions and cardiopulmonary resuscitation have the potential to generate aerosols. They suggest that in the current COVID-19 pandemic, healthcare providers should use personal protective equipment for aerosol-generating procedures during resuscitation. They suggest that it may be reasonable for healthcare providers to consider defibrillation before donning personal protective equipment for aerosol-generating procedures in situations where the provider assesses the benefits to exceed the risks. Okay, does anybody have any questions or comments about these 2 studies before we move along?
I think we're doing well for time, so we can take a little pause and see if there's any questions or comments on the chat. I don't think there are so far. All right, we can move into the next. Sorry. If I learned anything from Jen during this presentation, it was I've found a number of new slide transition tools, which I didn't know existed. So thanks, Jen.
You weren't doing the sound effects like I thought you were going to.
I left those out for so far. So we also wanted to talk about personal protective equipment today. I guess early on during our experience with COVID-19, there were a lot of questions around PPE, and questions probably still do exist, but I think we've learned a lot over the past month. So for the last study, we're going to review the Vertosco study, which is a systematic review comparing medical masks to N95 respirators for preventing COVID-19 in healthcare workers. So we know that PPE is a limited resource, and based on our previous experience with SARS, the first coronavirus, we know that healthcare workers were at risk for transmission and made up 21% of cases. And I think there's been estimates that in some of the hardest hit areas that healthcare workers made up 29% of the cases. And the recommendation is that N95 should be used when there's aerosol generating medical procedures involved, and that medical masks may be adequate for providing protection, as it's primarily transmitted through droplets. And there's been a lot of discussion around options for preserving PPE in the context of knowing that supplies are limited. So there's been research on risk stratification, so trying to identify when the need for aerosol generating medical procedures might be incorporated into care, and then going with N95 during that type of care, but then medical masks during standard care. And then also there's been some research around the reduced or extended use of PPE. So in this study, this was a systematic review of randomized controlled trials. The population was healthcare workers, the intervention being medical masks. And I also learned that C is not only for cookie, but also for comparison. Comparison in this case was N95 respirators. And the primary outcome was viral respiratory infection that was confirmed by laboratory PCR. That's a pretty robust outcome, and an objective outcome as well. And this was an update from a previous systematic review by Smith and colleagues back in 2016. So they want to duplicate the methods and conduct a similar review, adding to that body of knowledge. So in this design, they removed the simulation in studies involving mannequins, so that's more indirect evidence, and conducted randomized control trials. The research was fairly robust, with including Medline, Embase, and Cochrane, and they searched from the date of the last systematic review, so January 1st, 2014, to March 9th, 2020. So they really just wrapped it up in early March. Pretty amazing that it's now out in publication. In terms of study design, it was a full systematic review. They did use a single reviewer to extract data, and then they had a second reviewer to complete a quality control of the data extraction. They also had completed a risk of bias assessment using the Cochrane risk of bias tool, and then also looked at the certainty of evidence using the grade approach, which also accounts for risk of bias, inconsistency in the results, and indirectness, imprecision. So in terms of their results, this is the flow of studies identified through their search. And really, they only identified one new record that wasn't identified in that earlier systematic review. So that was the study by, I don't see it here, but it was a 2019 study. So this is the evidence profile of the 4 studies for each of the reported outcomes. The one that we're most interested in is the laboratory confirmed respiratory viral infection. And there was no difference between the medical mask group and the N95 group. We'll get to a little bit more detail here. This was the risk bias assessment. So there was a low risk of bias for selection bias. So this just that they did use randomization procedures and allocation concealment. And then in general, there was low risk of bias for attrition bias. So there wasn't a lot of missing data and reporting bias there. So all these studies, I think all but one published or registered their trial prior to doing the research. So that was all pretty good. So you'll notice that under the performance bias, all of those are red. So it's really blind the participants to whether they're wearing a medical mask or a surgical mask. So that would be expected. And then of the interest might be this detection bias, where for 2 of the studies, they're able to blind the laboratory personnel to the out, so they didn't know what group the participants were in. And then in 2 of the studies, the McIntyre studies, there was no mention of blinding for the outcomes. So there was the potential for a detection bias. This is a forest plot just highlighting the results once again, and you can see that the diamond at the very bottom is the overall effect size. It crosses the 1, so we can say that it's not a statistical significant difference. And I'll show that the forest plots for the other 2. We can get into a little bit more discussion around forest plots if people wish, but there's a little bit more imprecision in the estimates and lack of consistency, in particular in the clinical determination of respiratory illness, bottom forest plot. But some people on the line might not like this term, but there seems to be a signal favoring N95 in for some of the outcomes. There was only one study that identified laboratory determined or infection with coronavirus, and they're all previously known coronavirus. And there was no difference between the medical mask group or the N95 group in transmission of coronavirus. And I thought this was interesting. They also looked at work-related absenteeism, and there was no difference between both of those groups as well. And this was the only study that looked at absenteeism. So in conclusion, this is what the authors concluded, there was no convincing evidence that medical masks are inferior to N95 respirators for protecting healthcare workers against laboratory-confirmed viral infections. So that was the primary outcome during routine care and non-aerosol generating procedures. They thought that reduced protection from medical masks can't be ruled out at this point. There's low certainty of the evidence, and this is mainly as a result of the indirectness. So there's no research specifically on the SARS-CoV-2 virus. And then I think I might bring this up later, but also from our standpoint, I think there was only one study that talked about EMS being involved in one of the clusters. And for aerosol generating medical procedures, the recommendation would still be N95 masks. In terms of limitations, there was only one trial that reported on coronavirus infection, and it didn't include the SARS-CoV-2 virus. I was also slightly concerned about the fidelity of the intervention. So, in a couple of studies, I think it was the McIntyre studies, they talked about in some clusters they might have had fit testing, and others they may not have. So, I guess they might not have all been equal in terms of how the medical masks or N95 masks were rolled out in each of the clusters. And then there was only one study that talked about including emergency transport services. And this is it wasn't really well defined. I couldn't find much information about how that group in particular. So whether we still don't know a lot about how medical masks or N95 masks perform in the conditions where we work, where we might have some environmental variables. I know in March we had a couple of winter storms here in Nova Scotia. So how does that contribute to the effectiveness of PPE? And then I'm sure they're having issues in the south and in the U.S. with tornadoes and different storms there. So those add to different challenges with the potentially add to challenges with the effectiveness of PPE. Jen and I also wanted to highlight that action bias might be playing a role, and this can lead to an over or underestimate of the effect. So, based on our pre-hospital evidence-based practice program methodology, we would say that this is a level 1 study. So it's a randomized control trial or a collection of cluster randomized control trials. So we typically would say that's level 1. We do have a caveat within our CAP groups that downgrade studies if they haven't described their sample size or they weren't powered effectively. I don't think that was an issue here. It seemed like the systematic review authors in particular accounted for the study design and the cluster randomized trials and tried to statistically account for any challenges around sample size. And then in general, we would say that both medical masks and N95 would be supported, so they'd both be green within path for use. But we could discuss that as well. So in terms of rapid reviews, so as Jen mentioned, rapid reviews are quite helpful for quickly reviewing the literature, and typically they're conducted in 1 to 6 months as compared to full systematic reviews can take 1 to 2 years. And there's often pieces of the methodology that might be cut back to facilitate the rapid review. You might just have one reviewer doing certain tasks, or you might look at a shorter time frame for the literature. Those are two ways where you can take a few shortcuts. And then from an end user using rapid reviews, I think it's important to be able to trust the resource that is putting out the rapid reviews, and then also thinking a lot about the question that they're asking, so the PICO, the population intervention comparisons and outcomes, and how well that aligns with your issue that you're dealing with in your clinical setting or organization. I just wanted to highlight a couple of organizations that are pumping out a lot of rapid reviews at present. So the Center for Evidence-Based Medicine from Oxford University, and also McMaster University has a hub for COVID-19 rapid reviews. So these are great resources. So we do have some time for discussion. I'm not sure if we are able to take the unmute everyone, or if we just want to try using the chat. But we'll open it up for questions or comments from the group. I know there are others on the line who have expertise in this area around PPE, and then it'd be interesting to hear about experiences with providing cardiac arrest care to COVID-19 patients as well. I don't think there are any no questions so far in the chat. We'll just pause for a moment. Are we able to take the mute off everyone? Should we try it and see what happens?
But
Okay.
if somebody indicates in the Q&A section, I can definitely unmute them if they can't do that themselves, for sure.
Okay.
Just, I'm watching the Q&A in the chat, so if anyone does want me to unmute them, please let me know.
Do you have any final thoughts, Jen, on either cardiac arrest or PPE?
I thought this systematic review was terrifically done. I really like the methods. I like how they handled the data, and it was very impressive how quickly they got it completed. So props to them. It's an important review to get done in this time. So I appreciate the authors for that.
Yeah, I've been pretty amazed with how fast people are pumping out research right now. Daniel. Oh, I lost it. There's a comment.
You see that on your own there, Judah?
Maybe.
From Dan?
Oh, the in-hospital cardiac arrest results are fairly bleak. So, yeah, that is disappointing. And Jen and I did have some discussions about whether there are implications for us as in emergency medical services. I know in Jason's narrative review that he published in CGEM, we talked about really thinking about using validated termination of resuscitation guidelines. And then also, I think this is where we can start talking about frailty, but also thinking about what the goals of care are early for the patient. Have they identified any specific goals of care that the family are aware of prior to the arrest? And really having that conversation up front.
Judah, can I add something in here?
Sure, yeah, that would be great.
This is Janelle. One of the things that we have, and you'll see if you were on the webinar yesterday, we talked about it a little bit, but you'll see soon the sort of modified cardiac arrest guidelines come out. But that goals of care thing is really important that Judah just mentioned. And also, we're not generally transporting patients if they don't have a ROSC, and that kind of leads into this a little bit as well. The risk of disease transmission is higher, and also, of course, the numbers are quite low as well. So we shouldn't just be transporting patients. There is some termination of resuscitation sort of guidelines, and there hasn't really been any created specifically for COVID, but we do use those as BLS or ALS, and so to keep that in mind as well. So that the research isn't showing that these patients are going to do really well. So we're not necessarily doing anything, any sort of disservice by keeping these patients in situ when they don't have a ROSC.
And Dan brought up a good point. So should we treat or assume all pre-hospital cardiac arrests as non-COVID until otherwise determined? I think that was discussed a bit yesterday. We really want to think about reversible causes and start planning your interventions early. Do you have any follow-up for that, Janelle?
No, correct. Yeah, give online a call if you need to talk about reversible causes, and again, do that early. We generally, we're going to work these patients for about you're going to start to consider what you're going to do with them in about 10 minutes, which is quite quick, and just a few rounds of resuscitation. But that 10-minute mark is when you're starting to think am I terminating? But if you're considering reversible causes, you do want to call early, kind of thinking, if you're 30 minutes into a resuscitation and you're like, oh, I wonder if this is a PE and I should do something else, or if it was a tox and I should do something else. 30 minutes is a little long. So think reversible causes, call online early for some discussion and feedback as needed. And as somebody mentioned there, that we should treat all of these as suspected PUIs, wear your high risk PPE, and follow the guidelines that we've sort of created to reduce risk. All of these things really, it's not about changing patient care. You're still defibrillating, you're still doing compressions, you're still managing an airway, but you're just doing it with the safety in kind of eye or front of mind.
Right. Awesome. Any other thoughts from, I think there's a few people from other services across Canada on the line. Anything, we've talked a little bit about our practice in Nova Scotia.
A couple questions in your text there, Judith.
Can't see it. Give me a second.
I can answer a couple of these, and I'm sorry if I missed some. I do see one, and I'm not going in any order. Some just flashed up here. There was a question about early intubation, and we have removed intubation entirely for the breathing patient, unless it's some sort of upper airway etiology where you really need to do a risk-benefit analysis. So something like a burn or anaphylaxis, where it's going to be really important that you need to secure that airway. But otherwise, intubation's been removed. And in the cardiac arrest setting, it's a surgical mask or some sort of cloth over the face while you get started, and then an eye gel early with the full circuit with your filter and your extender once those are out, your BVM, your end tidal. So have that all set up and bag the patient early. So it's eye gel early, basically as soon as you can, and then start ventilating that way. And that's how we're securing that. And really the only reason we're going to intubate a patient that's in cardiac arrest is if for some reason we cannot get that eye gel in, but we have them for pediatrics and adults, so this shouldn't really be an issue. And for the most part, when we're looking at these calls, that's exactly what's happening now. And the culture sort of shifted that way anyway once we got the eye gels, that they're almost just as quick to put in as an OPA and a non-rebreather with passive oxygen. So we are generally going to the eye gel quite early, and if it's working, we never take it out to switch to tube. So it's sort of just following the practice that we're used to. So good question.
Thanks. I didn't know this whole other area existed with the question and answer. There's a few.
It's really hard to see, Judah, when you're presenting. So, yeah.
I missed this whole area. So it sounds like Janelle answered.
I will follow up though. Sorry, there was a subsequent question about why was it removed, and really with COVID, all of the work and the literature and the subject matter experts are saying if you are intubating a COVID patient, it should be in a really good environment with the best clinicians possible, using video laryngoscopy, using RSI, and it's just like almost the most ideal condition. This is not the time for the person who's just trying to intubate for the first time or hasn't done it in a while. So someone that's really experienced, and again, they're really saying must be with RSI and video laryngoscopy. So so for that reason, that really is not our realm to be able to do that. And so we're doing everyone a disservice and putting increased risk if we decided we were going to be intubating patients. So that's the main reason one of the main reasons it's been removed. The eye gel and the cardiac arrest works really, really well. There's research out there that shows they're both good as long as you're watching your airway pressures and you're not overventilating, which then could cause a leak if you've got too much pressure in the chest. But there's lots of good reasons why we removed that.
There's some really good, sorry, Judah. I was just going to follow that by saying there's some really nice resources on the AIM website. There's some great videos that have just recently been posted about the specialized approaches in COVID or suspected COVID patients.
That's great. There was a question or comment about rapid defibrillation prior to full PPE could be acceptable. It was unfolding after initial contact.
I looked at the ILCOR study where they investigated defibrillation in terms of risk for generating aerosols, and the reason I believe that they came up with that recommendation was because they couldn't uncover any literature that discussed that.
I think so. It might be maybe Janelle would jump in here, but it might be reasonable to put a mask on the patient and defibrillate if you have a shockable rhythm.
Yeah, absolutely. There's a lot of it. Kate just put out a position statement as well. There's a lot of, I'll say debate, but research that goes either way about defibrillation and compressions. More so on compressions. Some people say absolutely it's aerosol generating, and some are like, nah, not so much. And there's like two different camps there for the research. Defibrillation is one of those as well. Not as much sort of polar opposites, but a lot of the times that's even with the bystander stuff. They're saying throw something on their face, like cover cloth, a t-shirt, or whatever it is, just in case, and do that defibrillation early. So if that patient, you kind of witness that, if you're in a surgical mask and you've got something over their face and you defibrillate, that's pretty safe. To defibrillate early. But generally, we don't start compressions until there's something over their face.
Right. And I think you talked about Jean's question around is the service doing intubation early? We're doing eye gels in general, and we had a discussion around that. There's a comment about do we review any papers regarding cleaning and reuse of N95? We didn't for this journal club, but I have looked at a number of papers on optimal methods for reuse. There are some alternatives. I think one that stands out is vaporized hydrogen peroxide, and I think there's some good evidence for the use of UV as well. But in general, they're studying. There's a number of different modalities that they are studying, and the concern is that you ensure that you're killing the virus and then not damaging the filtration, and also not affecting the fit of the mask. So there's a lot of research coming out around reuse of PPE, and I think some viable options. And then there's a comment about access to NSHA guidelines. I think we probably do have access to those, and we can post those or that link. There's a comment from Rachel in BC. Our service is not intubating at the ACP. No ongoing exposure until decent. When the outcome is so poor with asystolic arrest anyway, I'm wondering about the efficacy of starting resuscitation efforts as well. And yeah, some discussion around eye gels versus intubation. So there's some, differing thoughts on what is preferred. And then the last question that I see from does Nova Scotia have manometers on their BVMs? So yeah, we do add the manometer. And then,
we really do focus on making sure we don't go over the 20.
Mm-hmm. So we're coming up.
I'm trying to post something to the Q&A. I just wanted to put a link to an article, but it seems like I can't post something.
So,
yeah.
Janelle, can you put in the response in the box?
I'm trying to put it, but it won't even let me hit send. It's just.
Yeah, so I had that problem. So I just put it in the box, and then I kind of click above it, and then somehow the send seems to work. So I'm not quite sure what the deal is there, but I did get it to work. Or you can text it to me or email.
I got it.
Okay, there you go. Yeah.
I don't know how helpful it's going to be with just saying it, but there's a good paper about IGEL versus ETI. It's on PubMed. It was from 2017. And it's anyway, there's a few different things. There's also some stuff from from the AHA. But anyway, there's lots of stuff that you can find out there. You'll be able to find both camps for sure. But also looking at safety and one of the big things about the optimal conditions for intubating, and there's a lot. You can go to the AIM Airway site as well. It's a repository of great information right now. So if you have any questions about airway stuff, that's for all kinds of different levels. That's a really good place to take a look at, and it's all open right now for anyone to look at. So that's the AIM Airway George Kovach site.
Awesome, thanks, Janelle. So we're coming up on 1 o'clock. I believe we have recorded the session, and we'll post it on the Dalhousie Division of EMS site, and also internally, I believe, and potentially through the NSHA as well. And Jean, do you know if are the Q&As saved recording, or those?
Yeah, I'm going to save them before I shut it down. Yep, so I'll save those and pass them on.
There's a lot of resources within the Q&A section as well.
Exactly.
Yeah, awesome. So we'd certainly appreciate your feedback, and we're open to having more journal clubs over the next few weeks. And if there's anybody who would like to present on an article, we'd certainly appreciate your help as well. Maybe one more question. Is there a question from Jean? Oh, which one? You know what the question is? Why has intubation been removed? I can. In Nova Scotia, it hasn't been removed. We're just going to iGel first, but it's certainly an option if paramedics think that they're in a position to intubate, and they think that's the best option.
Yeah, it's really only if the iGel we can't get the iGel in, or if it's something that really the risk of not doing it far outweighs the risk of doing it, I guess. So things like upper airway etiologies, burns, and stuff like that. But basically, except for that, we don't want to do it in the breathing patient. As I was kind of mentioning, they need the RSI, generally negative pressure room, best clinician, all that kind of stuff. So it's quite risky. So we've really reduced.
Mm-hmm. So I think, we're at...
Sorry, Jen. I just saw your comment here about unmuting Jean. I apologize. Bear with me. Sorry, Jean.
Yeah, I'm not sure how to do that, but...
There you go. I apologize.
I was just going to comment. You guys have talked about this endotracheal intubation and iGels. I left some references on the questions or comments. There's been a few studies out of Germany. Jim DeCanto's done videos, so they're not studies per se, but they're showing that there's significant aerosol generation from an iGel as opposed to endotracheal intubation. So going to the iGel, I think you should look at those studies. They're black light studies, and I have a concern over iGels. I think that a direct line intubation is probably the smarter way to go. It'll depend on what you have in terms of pharmacology and all that sort of stuff. But if you have a look at the link, and it's a video that I showed from Jim DeCanto, he's actually using the salad technique. And I know this isn't research per se, but just have a look at it. He's using the salad technique to remove aerosol generation while he's doing intubation. And it's quite a profound video. And I know it's not AIM, but this stuff filters through the airway community fairly quickly. And if you follow it on social media, a lot of people are starting to look at this. So I would just suggest look at the two resources and judge for yourself what you think the information is.
Thanks a lot,
Jean.
Jean. Yeah, that makes a lot of sense. I think that reinforces definitely the idea of putting that iGel in immediately if you're going to go that route, and immediately putting your viral filter and closing the system with your closed BVM.
Yeah, but Jen, the point is it actually doesn't, and that's where the aerosol generation studies show that. as opposed to endotracheal intubation. So like, just look at the videos and we can always talk later. I know they're not the same sort of rigor of research of what you do, but us airway geeks play around a lot. So maybe someone will do better studies.
I know there has been some discussion around leakage with the eye gel and reducing, I guess, the ventilation volume.
Yeah. Anyways, have a look. Just something to think about.
Okay, yeah, so we've recorded the session and we'll keep the Q&A as well and make that available. But I'd like to thank everyone for joining, and if you have any feedback, please feel free to email Jen or I, and if you want to present, you can see that as well. So thank you.